I'm going to be going over readiness for extubation in the pediatric population. This is for respiratory care 443, current topics in respiratory disease. Extubation in the pediatric population. So oftentimes there's a lack of standardization in the protocol to assess readiness to extubate within hospitals. We're definitely going to get into that in this presentation more, but things that can become of the lack of standardization is just missing clinical indicators that may come up from physician to physician within the hospital, missing key signs for what one may prefer, what the other, and things to indicate not only good times to extubate in clinical indicators, but also indications of failure when the patient is extubated. So this information by Tan et al. Found that the failure of standardization, there are 30 to 60% of unplanned extubations that are successful and do not require reintubation. So I think that's a good sign that 30% to 60% of those cases that are self-extubations or unplanned extubations were in some way or another able to be extubated. And therefore, whether it was an appropriate time or not, could have potentially been looked at for a daily spontaneous breathing trial, or could have potentially shown signs and that they were ready for extubation and done it in a more safer manner. So with a protocolized approach of daily SBTs with certain criteria that maybe could have been caught in a safer manner. So extubation protocols, as we just discussed, there's a big lack of standardization from them, and readiness, and this can lead to missed opportunities to extubate, as well as potential missed clinical indicators to predict successful extubation. So in the study by Vahidim Azimi et al. 2020, 4,200 patients were reviewed, 22,075 patients were reviewed with protocoled weaning, 2,125 of those without protocoled weaning. So the protocol group had superior lung compliance, NIF, negative inspiratory force, and RSBI, rapid shallow breathing index. Early reintubation, defined by reintubation after 48 hours of extubation, was lower in the protocolized weaning group, as well as late reintubation, so after 48 hours. In the same study, they concluded that protocolized weaning with RT-driven extubations is safe, effective, and associated with decreased reintubations early and late. Shorter hospital stays, increased intubation duration, statistically, but not significant. So this study found, in a summary, that RT-driven protocols with protocolized weaning led to safer extubations, improved lung factors, and did not lead to higher reintubation rates or failed extubations because of the quicker route to extubation. So it did it in a safe manner. So more on protocols, the variable approach, as we discussed, in weaning standards within the pediatric population is great. Early extubation reduces risk of complications such as ventilator-associated pneumonia, sedation complications, lung injury, and delirium from ICU level care with that sedation on board, and just the whole environment, many factors. Extubation weaning protocols can be an effective way to reduce the time of intubation, as we saw on the last slide. In a study conducted by Helwani et al., they looked at a 3-hour extubation protocol in patients post-cardiac surgery. They found that 217 patients pre-protocol implementation and 255 post, baseline characteristics were similar for them. The median extubation time was reduced by 44% in the patients that fit the 3-hour protocol weaning. So it's just reducing the intubation time by almost half is a huge deal for these patients to get them out and breathing on their own. That protocolized weaning is a great kind of fast track with key points to be able to hit as they come up from the cath lab. RT-driven weaning and extubation protocols have been shown to be effective in shortening mechanical ventilation time, largely attributed to assessing and trialing patients on SBT earlier than physician discretion. That one kind of depends on where you work. Some of us may be working at large teaching facilities and hospitals where there's residents, fellows, and attendings almost everywhere, in and out of the room all the time. Or maybe you work at a small community hospital where this might be a little bit more prominent, and you might already have protocols for extubation and weaning set in place. But a lot of times the physicians won't be directly at bedside. So having the RT there, someone who knows exactly how the patient's doing, their current status, how they're trending on an SBT, and if they're looking good enough to potentially extubate, you'll be able to get to that point a lot sooner than relaying that information to a physician, having them make a decision, and then passing that decision back on to you to act upon. So RT-driven protocols have been shown to be a lot quicker at getting to the weaning and the SBTs, and then to the extubation as a result. So in a study of 520 mechanically ventilated patients in an ICU conducted by Raza et al. 2020, looked at the effect of RT-driven protocols on the effect of ventilator weaning. The study concluded that respiratory therapist-driven protocols and interventions in a MICU result in a significantly shorter duration of weaning time compared to control groups. Shorter weaning time did not result in a significant increase of failed extubations. So a lot like the last slide we talked about, the RT-driven protocols for weaning showed shorter times of intubation and quicker extubations. However, it did not have any correlation with increased failed extubation. So that's doing it in the safe way where the patient's shows good signs that they're able to be extubated. Early extubation. So despite prior beliefs, recent studies have not shown any link between early extubation and BPD in neonates. Later extubation was associated with the complications involved in longer mechanical ventilation, as well as early extubation had an overall less risk of developing BPD. This is from Soderstrom et al. In 2021. Studies suggest greatly improved outcomes in neonates with early extubation. And so things that improved with early extubation were reduced risk of ventilator-associated pneumonia from things like circuit disconnects, invasive procedures, growth in the endotracheal tube. I think no matter how well your hand hygiene is and how much you try to keep the endotracheal tube as clean as possible, disconnecting for things like suctioning, maybe bronchoscopies, so many different things can and will usually lead to endotracheal tube cultures and growth. Early extubation also showed improvement in cardiac function and reduced costs of ICU level care, which I think is very important for hospitals, billing, and a lot of the major hospitals, profit or nonprofit, that run as a business. And that's obviously a huge concern from the very highest management down. And it was also associated with decreased chance of sedation issues, ICU delirium, and quicker recovery with PT-OT. Those are all kind of related, but obviously the amount of sedation required to keep someone intubated safely without self-extubation is pretty great. So high chance of developing ICU delirium. And some intubated patients at my facility will work with PT or OT, but it's obviously a modified version. They're not able to do too much movement or facilitate too much recovery while they are still intubated. So getting them extubated as soon as possible helps them recover. It helps them get transferred to a lower level of care much sooner. And then this last bullet point, just discussing, kind of recapping the issues that can accumulate when patients remain intubated for a while. And it seems like the longer patients are intubated and mechanically ventilated, a lot more problems occur slowly and over time, just from maybe medication toxicity, different levels of care, complications with care. There's a lot of drawbacks to a lot of different types of care and what you're doing in an ICU. So there's a lot of side effects and complications that slowly build up the longer they remain intubated. So ventilator weaning, extubation readiness, CPAP pressure support trials are generally the most popular ways to determine readiness for extubation. SBTs, or spontaneous breathing trials, are a trial on CPAP with a very minimal pressure support, previously thought just enough to overcome the resistance of the endotracheal tube, depending on the size of the ETT. Variables when the patient is on a CPAP or SBT trial to watch for include work of breathing, heart rate variability, end tidal changes, as well as desaturations, and generally just looking at the patient, their work of breathing, and their overall clinical picture is very important. These are often ordered in time frames, so maybe 1 hour, 2 hours, depending on how well the patient's doing, to exercise their lungs, as well as to trial them for extubation. A lot of times at my facility, we go CPAP pressure support directly to extubation, and the amount of time on those trials is really up to physician discretion and how the patient's doing. It's also very important to look at things on the ventilator, such as tidal volumes, minute ventilation, to show how hard they are working and how much volume they're getting through that. One study, however, did show that regardless of the endotracheal tube size, pressure support breathing trials severely underestimated post-extubation work of breathing and overestimated it by 126 to 140%. So that kind of contradicts itself right there, but that's saying that they underestimated post-extubation work of breathing, and the pressure support provided them more support than what they would traditionally be getting breathing room air after by the 126 to 147%. And pressure support did not accurately assess readiness to be extubated. This is by Robinder et al. In 2016. With that, he also found that CPAP underestimates or overestimates work of breathing by about 30%. So in summary, CPAP, while the patient's intubated, is harder than it would be to breathe on room air by about 30%. And CPAP with a pressure support, regardless of the endotracheal tube, is about 126 to 147 times easier to breathe on than post-extubation while on room air. So extubation readiness values, oftentimes they look at NIF or MIP or RSVI, that's negative inspiratory force, maximum inspiratory pressure, which are the same things, as well as rapid shallow breathing index. NIF and MIP should be more negative or less than negative 20, and normal is about negative 100. Greater than negative 20 just indicates that they aren't able to, their respiratory muscle strength is weak, and they aren't going to be able to take adequate breaths to be ventilated. RSBR AI is rapid shallow breathing index, and that's respiratory rate divided by tidal volume in liters. Prediction of failure is between 105 and 120. So just to touch on the kind of non-standard approach to a lot of pediatric extubations, almost every place I've worked at used NIF and MIP and RSBI heavily for extubations. My current facility doesn't. I've actually taken a NIF on, I think, 2 or 3 patients, and they were neuro patients, so just kind of seeing their diaphragmatic function. But it's not really not heavily relied on, I think, at all. So that just kind of shows the non-standard approach to a lot of these. These are very common practices that I'm sure many of you guys use and use consistently. However, where I'm at, a large teaching facility, they do not use them. Commonly, I should say. So extubation readiness, and Okamoto et al. 2019 conducted a survey reviewing extubation and ventilator weaning protocols amongst 248 patients and their post-extubation respiratory failure PERF. Found that reintubation rate is associated with a 5-fold increase in death. Low hospital mortality in this study was mainly a result from low reintubation rates. So this really encourages having a standardized approach to extubations and weaning, making sure that all variables are accounted for and no clinical indicators that may possibly indicate failure of extubation are missed. Oftentimes reintubations could be rapid or emergent, and as this stat suggests, the 5-fold increase is we really want to avoid if possible for things that could otherwise be easily avoided. So extubation failure is primarily a result of hypoxemia and hypercarbia from respiratory failure, decreased muscle strength, stridor, airway inflammation, as well as the underlying cause of intubation not being fully resolved. In a lot of the studies that I read, about 50% of the cases reported were cause of stridor, and children under 7 years old do not accurately are not accurately assessed with a cuff leak test to determine airway inflammation and stridor post-extubation, as well as adults are. So it's really, you aren't able to assess that fully while they're still intubated. So as we discussed in this presentation, extubation and weaning in the pediatric population is highly variable between hospitals and physicians within those hospitals. So RT-driven protocols may be a great way to standardize the approach to weaning and extubation, provide safer extubations, quicker weaning times, and reduced ICU costs, as well as the associated complications of mechanical ventilation, as well as failed extubations. Models are being studied for implementation of respiratory protocols at many facilities and showing great outcomes with improved extubation and weaning times, as well as ICU costs because you're not paying the physicians the same. And I think on another note, it provides great value to the RT service. So here are my references, and thank you all for listening to this presentation.